Good morning, everyone. I'm Leslie Cantor, and I am the chair of the Department of Urban Global Public Health at the Rutgers School of Public Health. I just want to say a few things about this seminar series, and then I will introduce our wonderful guest speaker, who I know you are all very excited to hear from. This seminar today is part of our 21st Signature Series webinars. This is in support of our core foundational areas of education, research, and community engagement, all guided by the principles of social justice and health equity. The theme for this year's speakers is Racism is a Public Health Crisis, a Call to Action. And just a couple of quick housekeeping things. I think you were all notified as you entered that we are recording this webinar and we will make it available. I've already been getting chats that people have students and colleagues who had hoped to be here and weren't for some reason, so we will make it available. Please feel free to put your questions in the chat as we go through, and our wonderful communications person, Courtney, is going to help me make sure that I don't lose track of any of the questions so that those all get asked at the end. And we do encourage you to live tweet from today's event, and please tag at Rutgers SPH. So I believe that those are the housekeeping things. And again, people are continuing to fly in. We have about 100 people with us right now. So that tells you about Dr. Nwako, the respect that people have for your work and their interest in the topic. So with no further ado, let me introduce you. Dr. Nwako is the Camden County Health Officer and Public Health Coordinator. He is, very importantly, an alumni of the Rutgers School of Public Health. And as if his job wasn't big enough, he is also the immediate past president of the New Jersey Public Health Association and past president of the New Jersey Environmental Health Association. He's worked in the field of public health for 23 years. His bachelor's degree is in animal science, and I already mentioned his MPH. His doctorate is in health sciences from Seton Hall. Camden County is the first and only county health department in New Jersey to be accredited by the Public Health Accreditation Board. So maybe you'll tell us a little bit more about that when we get into the Q&A. In case anybody here is interested in pursuing that path, we do have some municipal health leaders who are here today. Dr. Nwako started his public health career at the New York City Department of Health. He's a diplomat at the American Academy of Sanitarians. He's received numerous awards locally, nationally, and internationally, and he is a very desired guest speaker who has joined us several times, and we're just absolutely thrilled to have you this morning. And certainly you can tell from the number of people who've shown up that they're so excited to hear about your talk, Poor Health Outcomes Among Minorities During the COVID-19 Pandemic. Is this a surprise? So with that, let me turn it over to you.
Thank you, Dr. Cantor. And thank you for everybody that logged in. I hope this will be a good opportunity for you to know what we do in public health and why there are disparities in the healthcare systems among minorities in the United States. Okay. All right. Okay, so I want to start this by remembering 759,552 people that perished from coronavirus in the United States. And out of that, 25,358 perished in New Jersey. These are people's grandparents, great-grandparents, mothers, fathers, uncles, nephews, nieces, cousins, friends, next door neighbors. And I wouldn't start this presentation without remembering all these people that passed away from coronavirus. We wished we could have saved them. We wished the vaccine came earlier. We wished public health would have done so much more before the pandemic. But this is where we are today. I want to acknowledge all the public health workers in New Jersey and around the country, and indeed around the world. They are the heroes. So those public health workers did a lot during the pandemic. Those are the people that made it happen, and people don't remember that the reason the hospitals are not overflowing with patients and people are not dropping dead on the street is because of the extraordinary work performed by public health workers working in public health departments in their country. And that's from yours truly. And I'm very passionate about it because whatever we hear is that the hospitals, the doctors, the physicians, the nurses, they're the heroes, but public health workers are really the heroes here. So who are we? Public health workers, we are here to protect the rights of the poor and the underserved in the community that we serve. And like, you know, the students on this webinar, the science of protecting and improving health of people and their communities. So these are our heroes, one of them, in all areas of public health in New Jersey. If you go to CDC and you search poor health outcomes, this is what you get. COVID-19 racial and ethnic disparities. What can we do to move towards health equity? Health outcomes measures definitions and racism and health. So CDC defined health disparities as preventable differences. So I highlighted preventable differences because it's good to know. I'll say something at the end. It's preventable differences in the burden of diseases, injury, violence, or opportunities to achieve optimal health experience by social disadvantaged, racial, ethnic, and other population group and communities. So why is this preventable differences? Because we know that these differences in disparities among the minorities should be preventable, and it can be preventable if we put more effort into public health and things in our neighborhoods. And I will explain this more as we go down this presentation. So before the pandemic, how is disparity in public health explained? So some of you have seen this, Dr. Kamara Jones, who was also the president of American Public Health Association. There's a Gardner style that she presented. It's in YouTube and other areas that you can search for it. And there's a racial disparity in healthcare, and she broke it down into institutional racism, personal racism, mediated and internalized racism. And she also had a TED Talk. The bottom line here is that minorities are likely to die from colorectal cancer, stroke, diabetes, cervical cancer, HIV. But the issue is not, it is the structure, not the behavior. And I'll get to that more as we go into this presentation. Many people think about racism as something someone does to somebody. It's not that. When it's structure, it's the structure, not the behavior of people, the structure in place that's causing the racism, not the behavior of people that are coming down the pike. So poor children are more likely to be poor adults. It's a well-known fact. And it starts with the segregated school system, the poor school districts, adverse growth outcomes. It goes into increased rate of chronic diseases, increased exposure to air pollution, and increased rate of homicide and other crimes in that community. And it's the way it's built. And all those put together, you have a decreased longevity among the minorities. So also if you start rich, you are likely to stay rich than when you start poor to become rich. There are so many parameters around it. So you talk about the median home income, you talk about home ownership. Minorities own less home than other ethnic groups. You have rich people getting richer, and it's nothing wrong with that, but it has to be in a situation whereby families should be able to live well so that they can thrive well in their communities. Average family wealth are lower in minority communities compared to other communities. And then you have low access to quality healthcare, even with federally qualified healthcare centers in minority communities. Even with them, there are disparities because it's all about what Medicaid can pay. So they don't have the best quality healthcare that they can get in their communities. So your zip code actually determines the longevity, the sociogenetics. So when I was growing up 40 years ago, we were told that your genes, what your mom and your dad gave you, would determine how well you live. So I recently checked to see my neighborhood too, put in my address, and I was told I'm gonna live up to 81. I was shooting for 100, and I've been working so hard, exercise, eat well, but I might just live up to 81. I hope to live up to 100. And when you look at that, you see Camden County is at 77.34 as a county, New Jersey 79.80. So if you live in New Jersey, you in Camden County, it's a lower age. You're expected to live less than the person living in New Jersey as a whole. So in United States, it's 77.30. Like Dr. Cantor said, this series is about racism as a public health issue. And there are other concepts that people might want to know, which you hear every day. Health equity, social determinants of equity, social determinants of health, structural racism, environmental justice. This is a tale of two cities. We're talking about Trenton here and Princeton Junction, literally miles from each other. But a person that today was born, raised and born in Trenton, would be 13 years, would live 13 years less than somebody raised and born and raised in Princeton Junction. And this is in the same county, literally miles apart from each other. But because Trenton is in the minority community compared to Princeton Junction. So this is a tale of two cities and how people thrive in these two cities within the same area in New Jersey. So how about a tale of the same city? We're talking about Newark. So we have that in the northward of Newark, somebody born and raised there can live up to 80 years old, but somebody born and raised in the southward gets to 69 years old. So you see the disparity here, just between one city, but different neighborhoods. Somebody in the central ward, 71 years, and in the west ward, 72.5. The same city, but different wards. So this is an overarching thing here with is going to be something I will mention very well in this presentation regarding health disparities and how it affects the minorities. You have poverty, you have environmental threats, educational inequalities. We know that people that do not have a high school diploma are bound not to live long compared to people that have bachelor's degree or graduated from high school. We have inadequate access to healthcare in minority communities compared to other communities. So why the disparity? The question is, what do you do? What do you do, or what were you doing during the pandemic? Who had the ability to stay home? Who had the access to personal protective equipment? Who had the access to healthcare? Who lived in more populated housing and multi-generational housing? Who is disproportionately in the service industry? All these questions, the minorities. So during the pandemic, people, when people had to stay home, some people didn't have a place to stay and people had to go to work. They used the public transportation, the buses. the trains, and they were exposed. And that we all had what happened in New York, whereby the transmission was so much widespread because of the transportation system, the subway, the buses. So the minorities are much more exposed than the other ethnic groups. And the bottom line here, disparities, is because of the structure, like I said before, not the behavior. I mentioned about social determinants of health, so I want to go through it. I won't dwell on it. It's how it contributes to racial and ethnic minority groups being disproportionately affected by COVID-19 because of income, occupation, like I mentioned, neighborhood and physical environment, and discrimination, which includes racism and associated chronic stress, influences all these topics in social determinants of health. So what are the consequences of COVID-19 on the minorities? We have the risk of exposure, which I've explained, disparities in COVID-19 illness. I will show you slides that contain cases of minorities being higher and disproportionately represented in cases of COVID-19 in all the areas. It's widespread in all the areas in the United States. So this is the county I represent, and you see Camden as of yesterday with 12,521 that are tested positive. It's about 70,000 residents. The next city is Cherry Hill, same population, different demographics with 7,083 test positives. So this is just an eye opener, but Camden County took this so good because we worked so hard to make sure that we don't have these disparities during the pandemic. And I'll tell you the things that we did. Somebody asked me, even with what we did, we got to this. It could have been worse. It could have been 4 times. So we had 1.67 times higher than the than Cherry Hill. So it could have been 4 times if we didn't do what we did. So the consequences of COVID-19 on minorities again, there's risk of illness from COVID-19 because at the time this was happening, a lot of minorities, they refused actually to go to the hospital. People stayed home. People felt that they wouldn't go because they don't want to get infected in the hospital, and people died at home. And people wouldn't let people in. They wouldn't even hear anybody. But we just, so many public health departments around the country did a lot to make sure that they got to the minorities and also to other members of the public. There are disparities in hospitalization and also deaths. I will get to that. I would also discuss issues regarding demographic and clinical characteristics regarding treating underlying medical conditions for minorities compared to other races. Such disparities around the country during the pandemic, differences in rates of hospitalization and the outcomes. Regarding death, we know that, and it's been stated and reported in so many studies, that minorities died more from the pandemic. I will show you how some of the outlets have been interpreting it, and also let you know how really it should have been interpreted regarding the deaths. Looking at it on a face value, you think the whites died more from coronavirus than the minorities, but I will explain down the line why it's explained the way it's explained to the community and the people that don't know public health and what we do. So in Atlanta, Georgia, from in March to April 2020, the people that was admitted in the hospital, 79% of Black compared to 13% of white. Bear in mind, Atlanta is 524,000 people. And 51% of that population is Black, 50% is Black, 41% white. So, but people hospitalized, 79% are Black. So you see that disparity. So even though it's half of the population, but close to 80% of people of color was admitted in the hospital because of what they do. And they are the people that go out there to do the work, and they actually got infected more. And 16,233 workers in the meat and processing facilities were infected with coronavirus. The people that were surveyed, 87% were racial and ethnic minorities, 87%. So this is the workforce of the country that's been impacted, and they are the minorities. So we're looking at also the positive results, test results of race and ethnic groups. And we see that the whites are at 7.0%. We have the Blacks at 13.8%. So we're talking about close to double of the number of people that tested positive between the minority Black and Hispanic compared to the white. And these are from studies that was conducted between January 2020 and August 6, 2020. They're all peer-reviewed studies. We're also looking at age-adjusted laboratory confirmed COVID-19 associated hospitalization rates by ethnicity rates by race and ethnicity. What did we find? We found that over here, non-Hispanic American Indian were at 1,553 compared to the non-Hispanic white 487. So you're looking at 3.2 higher. And then 3.2 times number of people that were infected in that are non-Hispanic American compared to non-Hispanic white. And then you have the Blacks and the Hispanics. So at 12.07, while the white is at 4.78. This is a huge disparity, as we are seeing. When we look at the associated hospitalization rate by race and ethnicity, we go all the way to the right. We see the non-Hispanic white, the rate ratio, look at 1.0 for age 0 to 17. So people of American Indian and Alaska Native are 3.1% more to have been hospitalized compared to the white population. And then you have the Black population and the Latino population, 3.0, Latino population 2.8, more likely to be hospitalized compared to the non-Hispanic white. And this goes down to other age groups, 0 to 17, 18 to 49, 50 to 64, and 65 and above. The highest being with the American Indian and Alaskan Native at 18 to 49. This is the age, this is the working age. This is the people that go to work and come back. And they are 5.2 times more to be hospitalized compared to the white. Across several studies, most found a higher percentage of hospitalized patients were non-Hispanic, Black or Latino compared to the whites. These are also studies on hospitalization. They looked at the median range of the people that tested positive and they were in the hospital. 44% Blacks, 16% white, and 36% Hispanic or Latino. All right, so some of the media, this is what they present, and they say that the whites, non-Hispanic whites, died more of the coronavirus compared to the minorities. But when you look at this, you see that the red bar all the way to the left is about, the red bar is the deaths, and then the blue bar is the population. Okay, so this is the population, the blue bar is the population of the whites, and the red bar, the population that passed away. But look at the Hispanic here. The blue bar is smaller, that's a small population, and look at the people that passed away. Compare it with this, the blue bar, the population, the red, deaths. Blue bar, smaller, red, higher. I'm just showing it that way to make sense to everybody, but I'll get down to it in the next slide. And also the Hispanic population with the Black, also the Black population. Look at the number of Black, the population here, and look at the number of people that passed away. But on a face value, you would think that non-Hispanic whites died more than other ethnic groups when compared to their own race and Hispanic subculture. COVID-19 unequally affected Hispanics, Blacks, American India, and Native Alaskan Native population. So this is also a slide that shows risk of COVID-19 infection, hospitalization, and death by race/ethnicity. And we see that in cases, the American India Alaskan Native is 1.7 times higher compared to the non-Hispanic whites. And for the Hispanic population, it's 1.9% higher compared to the non-Hispanic white in cases. When you go to hospitalization, you see that American Indian population is 3.5%, 3.5 higher. There will be 3.5 more to get be hospitalized compared to whites. So, and in deaths, they are 2.4 times higher to get to die from coronavirus compared to the non-whites, sorry, the whites. This is across the border for all the minorities, the Hispanics, the African Americans, and the Asian, non-Hispanic persons, and American India or Alaskan Native compared to non-Hispanic whites. So bottom line is that race and ethnicity are risk markers and on the underlying conditions that affect health. So there are unintended consequences of COVID-19 mitigation strategies. During the pandemic, what we didn't realize at the beginning was that the minorities would lose their jobs and maybe lose their health insurance in a higher scale that we have seen. That happened. Few of the experts during the pandemic talked about food insecurity. but it started being obvious. When people lost their job, children are not getting lunches from school, people stayed home. And that spiraled into a difficult trend whereby the poor people and the minorities, they stayed and become malnourished. And because people didn't have any job, getting food on the table became an issue. And people were asked to quarantine, stay home. And people were really, mostly the minorities, they were really hungry during that period. We also see that there have been housing instability. People, the minorities have gone through a lot of them through eviction. The federal government and some of the state governments provided funding for housing for people that are facing eviction, but it didn't come at a good time or at a time that we utilized. And in some cases, those minorities have been either gone through a more difficult time with interactions with their landlords, and also some of them have gone into homelessness or supporting with family members. And it took some time for things to start stabilizing. But the first people that were really hit by doing this is the minorities. Just want to make sure that people understand it. So 41% of US adults avoid medical care during the pandemic because of concerns. I did say this before, concerns. People didn't want to go to the hospital at the beginning. And we had a lot of mental health issues and bereavement. People didn't quite say goodbye to their loved ones. It wasn't right, okay? People didn't grieve very well during this pandemic. People that lost other people because of the pandemic. So there have been studies before this, before the pandemic, talking about Black households, how they are 2 times as likely to suffer from food insecurity than the national average. So we're talking about for the national average compared to 22.5 for the Black households. And Hispanic population is at 18.5. This was a survey done in March of 2020, just before the pandemic started. And the bottom line here is that there are higher percentages of food insecurity among Blacks and Latinos compared to other races. So what can we do to move towards health equity in a pandemic? Our emphasis should be on the minority communities. Those that have children, those that have family, know that you pay more attention to a child that's demanding and leave those ones that that can really take care of themselves are not more demanding. So you pay more attention to the minority communities as a public health practitioner. In the minority communities, there is a lack of trust as a result of past medical racism and experimentation. It took time and energy for public health professionals to really get into minority communities, because first of all, they will tell you, you don't come to them except if you're part of that community from the beginning. If you are part of that community, it is easier for you to come in and relate to them, even in a pandemic. So you build those bridges before there is a health crisis. You go into meetings, get your health educators, get people that work within the health department, the administration, everybody in line with those minority communities, so that when you need their help, when you want to reach out to them, they can hear you. If you go to them in the pandemic, they haven't seen you before, they don't know where you're coming from, everybody will walk away. So Camden County did something important at the beginning of the pandemic. We went to Camden City and we started giving out masks. We started giving out health education pamphlets, leaflets, things. We start telling people, do you have hand sanitizers? The little that we have, we give it out in the community. We build that trust in the community. So sometime in November, December of last year, we went door to door and we started knocking on people's door in Camden City. What are we doing? How can we help you? We did a study to find out who needs help. We started calling people, phone numbers that we can get, started texting. What help do you need? We're here to help you. Is it food? We were giving out, we opened up food areas that we hand out food for those that need it. Some of them say, hey, we are not here for handouts, we need jobs. We directed them to where they can get jobs, our one-stop shop here in Camden County. And most people that didn't have jobs had to go out and get jobs at this time. So what we did actually made a lot of news, and the Louisiana Department of Health reached out to us and we spoke to them, and they wanted to replicate what we did in Louisiana. And this is the product. They went door to door also in Louisiana, and it was modeled on what we did here in Camden County. I would like to talk about the work that we did with faith-based organizations, because in these communities, you have to tap into where they go to church, mosque, the temples, and you have to deal with those community leaders. Those are the people that they're listening to. People live in this community. Those are the people that they're listening to. We train community ambassadors with the health agencies that we had in Camden City and around Camden County. There are public health agencies. I won't fail to mention, there are a whole lot of them, and we work with all of them. We work with area hospitals. Cooper is our main partner. We have Jefferson Virtual. We work with the federally qualified healthcare centers. We work with AHAC. We work with Camden Coalition of Healthcare Providers. They helped us with training of community ambassadors in Camden City. And those ambassadors, we started training the pastors. We started training the imams, everybody that's a faith-based leader. We trained that person to be a community ambassador, to go to their people, to go to their the people they shepherd, to speak to them regarding how to get to them, to go get tested, to get the vaccines, to make sure that they do social distancing if they need help. At the beginning of the pandemic, people that were infected didn't have a place to go. They can't go back to their families, especially the minorities, because in where they live, they do not have enough space to isolate. What did we do? We started putting them in hotels. And initially we were paying for it, and then the state came and gave us some grants to pay for it. So this is what we've been doing here to make sure that, one, we reduce the infection rate here in the county, and two, that we reach out to these the communities that need our help. We also been working with policymakers. All the policymakers here in Camden County, we have a roundtable. We speak with the schools. We speak every week. We talk to the school superintendents, staff. Each of the staff members are assigned to each of the school districts. So if something happens in Camden City, there are staff members from Camden City that will be speaking to Camden City school districts. Each of the school principal can talk to our staff member direct any time of the day or evening. We have that in place here in Camden County. And that open communication between us and the school made it very important, easier for us to reach out to the community. because parents know that if their children are safe in school, then other things being equal, they can now move on with their lives. And the media, that's a good one. They can be a good source of communication, and also a bad source if you do something wrong. So at the beginning of the pandemic, I remember our group, we work as a team here in Camden County. We don't work as individuals, because if we work as a team, it makes it better for everybody. So on the 6th of March, our first case, and we were discussing it, we were told that we should come down. There are a few media that want to interview us. We got down and they said 5, 4, 3, 2, 1. Ladies and gentlemen, we are live. It was, we were like a deer with a headlight. And that was it. You can't make any mistake because you are live, and with most of the channels, news channels. And from our first case to our first death, everything went through the media. I want to show this, which is so good, and CDC put it out regarding how you should interact. And this works with all the, every public health emergencies and everything that we have to do at the public health department. We should be in contact communication with our schools, our civic groups, law enforcement, community health centers, corrections, that we are constantly in touch with them, the transit, fire, EMS, police, hospitals, nursing homes. During the pandemic, we had, at the point we were having weekly meetings with the nursing homes when we had, their numbers, we saw that there's a lot of people dying from the nursing homes, a lot of positive cases. We started talking with them every week. We started talking also with the jail, discussing with them, reaching out to them, knowing if they have issues, anything that we can help out with. Of course, I talked in depth about the first faith-based communities that we've been speaking with. Now, as a public health department, I should point out that we are severely underfunded. State and local health departments need 80% increase. So we are actually working with 20% capacity here. So 80% increase in our workforce to provide a minimum set of public health services to the nation. This is very important because the work we do is important to the community. What we do is to prevent. The hospitals control, we prevent. We want to get to people before they get to the hospital. And remember what I said at the beginning, the reason why people are not falling on the streets is because of the extraordinary work that we've been doing in preventing, doing contact tracing, case investigations of cases, so that the hospital is not overflowing with positive people that need hospitalization. So we are doing our best. This is another study here that the issue report that said that the impact of, talked about the impact of chronic underfunding of America's public health systems. Trends, risk, and recommendations for 2021. We are severely underfunded, and we are working, we are cut to the bones. All right, so these are the things that really keep me going, because as a human being, and in the face of all the things that have been happening during the pandemic, I've been seeing so many things. I've been called names. People have said things that I've never had that I did, and it's all a fiction of the imagination, but words start spreading, and Pascal did this or that. But what keeps me going is that it's part of the reality check. Other people liking you is a bonus. You liking yourself is a real prize. Just be yourself. Tomorrow is the result of what you do today. The limitation to your potential exists only within you. So I know that public health professionals can do this. We have the manpower. We have the strength to do this. And success is a marathon, not a sprint. And I can relate to that because I had to scratch off running a marathon on my bucket list that my director helped me being a mentor to do the marathon, and she pushed me to the edge and I had to do it. That was in September. So because this is academics, I have to put in references, and again, we are the heroes. And I will now open it up to questions. Thank you all for hearing me out. And I hope this will help you know where we came from and where we're going to reduce disparities in minorities in the United States. Thank you.
Fantastic. Thank you so much. I'll have my applause stand in for, for the 135 people who are here. It would be great, actually, if you want to stop sharing your screen, then people will be able to see you. And we are inviting questions in the chat. There is a question from Dean Menefeld, and I just wanted to ask if you would like to unmute and ask your question yourself rather than me reading it. Please feel free to do that. And if that doesn't happen immediately, I will do it.
Hello.
So much.
Go ahead.
Sure. I was thinking about all of the factors that you say that are likely to be impacted. When you think about COVID holistically and how it has affected the minority community, what are your recommendations for social networks, governmental interventions that could ameliorate the situation in the future, given what we know now?
Okay. All right. So let me start with, we all know that there is poverty among the minorities. And it's just something that the government will have to really address this, okay? If I want to go back to the initial slide at the beginning that I talked about, because that will be something that will help us towards, if a child today grew up in a community that's poor, that child is more likely to stay that way than go up. So the government will have to find a way. First, through public health, because we deal with health, and public health is linked to other areas like housing, environmental, and make sure we have good quality of life. So if you fund the public health department very well, the health part is taken care of. But then you come to unemployment. You provide training and employment in minority communities for them to be able to sustain themselves. Because what did we see? We went into Camden City giving them food. Some people will say, I'll take this food, but I don't want to be here every day. I need a job. I need something to sustain me and my family. All right. There should be a way to make sure that in minority communities, especially very poor communities, that children are provided the wherewithal to graduate from high school. Very important, because not graduating from high school is showing us that they might die on a timely death. Okay, they might not reach their potential. Okay, that they might end up in jail. They might end up. So you have to start from the beginning. Train them in school, provide them with what they will do when they graduate, and then you go from there. I hope I answered your question, but you can do a follow-up.
Well, yeah, I'll be frank. I've done some research in this area, and I don't really have a complete answer. I think it's important that governmental institutions work with community organizations. That chart that you had with all of the arrows and the connections, I think is real critical during a pandemic that governmental organizations facilitate those relationships and provide funding to those organizations. But all of those are short-term solutions. I think a more comprehensive look is needed, because if you think about structural determinants of health, at the end of the day, your job is to remedy the situation so that the next time there's a pandemic, there's no disparate impact on any particular group. But now that we know, I think those items you just mentioned, like increasing the educational level of the Black population, is one of the solutions, because now you can enter the workforce in positions that are pandemic proof. One of the key things I found out is a lot of minorities lost their jobs because they were not able to work from home. When you're in the social service or in the service industry, you can't work from home. It's either go to work or you're fired. And then, of course, if you get COVID, now you're sick, you have limited amount of insurance, and it catapults. You have children at home that you can't pay for daycare, and it spirals out of control very, very quickly. So it's those other things that the government needs to think about, how to, at the end of the day, if you improve the economic ability of people to be mobile, that is this whole idea that people don't want to go back to work. They don't want to go back to work because they weren't getting paid enough. So as much as I hate to say it, I kind of understand. If I was getting a check, I would probably stay at home too. We need people to go back to work. All of these companies that are making billions of dollars, they need to pay people more money so that they will go to work. If they go to work and they make more money, all of those other structures of determinants of health will start to decline. They will have better housing, better options for food, and the list goes on and on. Until that happens, I don't see things changing very, very quickly. Sorry for going on for so long.
Yeah, that's true. I mean, you're absolutely correct. I think I don't have more to add to it.
Thank you. So we are getting a bunch of questions. I'm going to combine a couple. Someone had asked about disparities in vaccination. And if you can say something about disparities in vaccination rates at this point. And while we're doing vaccination, Mary O'Dowd, who was the former commissioner of the State Department of Health, would like to hear your thoughts on encouraging vaccination among children.
Okay. All right. So I did say earlier that there's a lack of trust. A lack of trust as a result of past medical racism and experimentation, especially in the Black and Latino communities. And this is the first thing that comes to heart. As a Black man, as a Black person, I go to town hall meetings and people my mother's age will pull me aside and say, are you really going to take this vaccine? Do you want me to take it? Do you know the history? So it took time for us to really come to terms with this kind of situations. We have a low vaccination rate in minority communities. And here in Camden County, we have been successful in bringing that percent up. So before, I think it was in August, and thanks to one of the assistant commissioners, Lisa Sari, that is the county ambassador that came and helped us ramp up that with her team, that helped us come to Camden City and other municipalities in Camden County and help us ramp up that number. We are above 70 right now. So what happened is that we had to go door to door. We had to set up vaccination sites around those communities. We have what we call the pop-up sites, so they can go to XYZ at the park. The mayor was on the ground, sending out, walking on the street telling people, go get vaccine, go get the vaccine, go get the vaccine. We have a health education staff on the site there to make sure that their questions get answered. We had people in white coats going door to door. So we divided Camden City into codes, zip codes. So zip code A, B, C. This is where we have the highest number of people that are not vaccinated. So we went to that zip code and we start telling people we gotta be vaccinated. Yes, we had incentives, gift cards here and there, and other things that we use as incentives, but the most important thing is that we are reaching the community. Okay, so what do I think about the vaccination?
This is a Zoom meeting.
Mhm. Oh, let's see.
So what do I think about vaccination for 5 to 11? So as a public health official, I think that children should be vaccinated.
That's one of the meetings that I go to.
Receive childhood vaccination as infants, and that made us to go to school and mingle with other families, other children. I think it's a good idea that children get their vaccine, go back to school, because we are seeing high number of positives coming from schools, and schools want to make sure that they have a good number of students in the classroom. We know that education is better learned in the classroom, especially for that age group. The Zoom teaching over last winter and sometime during the spring didn't go well, especially in the minority communities, because some of them don't have Wi-Fi equipment. Some of them are distracted from other family members doing their thing in the house. So they better learn while in the classroom. And for that to happen, you need them to be vaccinated. Thank you, Mary, for your service also.
Thank you so much. Okay, so lots of questions. So this really has to do with sort of, are we going to be able to do some case studies around the issue that you raised about people who may have died or become much sicker because they were reluctant to get medical care? One of the issues that you mentioned early on, people who maybe became ill from their underlying conditions because of that fear. Really, like, how well positioned are we going to be to tell that story?
Well, I hope this doesn't happen again in my lifetime, to see this pandemic to this extent. And whenever it's going to happen, I think we'll be more prepared for this than we have ever been. We have seen cases here in Camden County where people died in their homes. It was very difficult because people didn't want to go to the hospital. There's a woman in her 70s, I think she was 77. She told her husband, go to the hospital. No, I'm gonna die. I'm gonna die in the hospital. He ended up dying in the house. The coroners came, picked up the body from the house. And the wife was saying, I told him to go to the hospital. Well, he died of a heart attack, not from coronavirus. So we will be better prepared, especially if you better fund the public health department and make sure that we get what we sustain, because we are working at 20% level. So what if we work at 50% level? So think about that, like at least double what we have, because right now it's 20% compared to 100%. We are 80% short of people that we should be working with. So let me leave it at that. Everything is in place now, that if this happens again, we should be able to be more prepared than we are. Yeah.
So I think you'll like this question. has to do with how the state can better support county and local municipalities. I'll read the question out from Emily Greenfield. So, reflecting on your experiences as a county leader in New Jersey, what do you think the state can do more of, better, differently to support the capacity of county and other local public health departments and their partners to more effectively move the needle on issues of race and health equity beyond just money? Although I suspect it would be okay if you'd mentioned more money too.
Yeah. So, so let me first of all say that during the pandemic, everybody didn't know what they were doing, especially the state. So they got it right. Okay, I give it to them. The beginning, it was a mess. It was a big, hot mess. But things have started going right now with the state. But where we are lacking is in communication. All right, we're in the age of communication, but still communication is not going the way it should be going. I feel for Shireen and her group at the Office of Local Public Health, because sometimes we get information before they do. And when we ask, they said, what can we do? So communication is the key here. It's very important that local health officers get communicated what's happening. And we are part of the planning from the beginning. You do not plan to start vaccinating children on Monday, and you're telling us on Friday. We have to be part of that planning, and we tell you, this is the things that you need to do, this is the way it should go, and we be part of it. Something else, when you look at the way public health is practiced in other areas, in other countries, especially in the UK, Britain, the public health department have the ultimate powers. Here, some of our powers have been reduced. I'm talking about the Public Health Council here in New Jersey. Okay, they used to have the ultimate power to do so many things. Those have been watered down so much. And it's one of the things that we've been clamoring on, to have that autonomy so that public health do not become politics. You have to separate from, those that know the Bible, Paul from Barnabas, you have to separate politics from public health. And I will stop so far regarding what the state can do. We can do a sidebar, because there are other things I might not be able to say here.
Excellent. So that's an important thing for the state folks who are on. Please follow up. Be sure to ask the question again. There are a couple of questions related to pandemic-related activities, and will there be more emphasis? So one was this idea of having isolation centers and something other than hotels, and then also a question about whether surveillance teams would be given more emphasis.
Yes. At the beginning, we opened up, we tried to open up a isolation and quarantine site over at the college. There were beds, there were a lot of things. Remember before the pandemic, we had emergency preparedness training in all these things. But what we didn't know is that we could be in an emergency for close to 2 years. We were only preparing for emergencies that will last for a week or so. So we had plan in place. And we had those things in place before the pandemic, but the pandemic is something that none of us have seen in their lifetime. And the preparation it was to handle the pandemic was so enormous, and it weighed us down so fast. It would be a good idea to have a regional quarantine and isolation site manned by the state, so that people from Camden County, the South, can send people there to properly isolate and quarantine, as the case may be. That's not in place. That has not been in place, but for the next pandemic, something like that should happen.
Thank you. We do have a hand that's been raised, so I want to make sure to allow that person to ask their questions. Stanley Weiss, please.
Yes, an excellent presentation and overview, very comprehensive. There's one puzzle in the data that you didn't comment on. And if you could go back to your slide, which showed the increased hospitalization proportion, increased mortality rate among minorities.
Yes.
It's not surprising that those ratios are elevated based on everything you said. And indeed, because we expect that systematically minorities come to the hospital later, come with more advanced disease, tend to have, therefore, more serious disease, I would expect that the mortality rates to be elevated. But if you get that slide up, you haven't shared your screen yet.
Okay, sure. Hold on a second.
I wonder if, just because it is clunky and there are a lot of questions, though, maybe we could just ask the question and Dr. Nwako could just comment on it since he knows the material.
Okay. Go ahead, Dr. Weiss.
So if you calculate the risk of death if hospitalized, it is much lower for minorities than whites. And that goes counter to everything I would have expected. And that's why I thought the slide going up would be helpful, because you didn't calculate the ratios there, but what you'll see is the relative risk for hospitalization is much higher than the increased relative risk for death. So if you do that ratio, that clearly shows that compared to whites, the risk of dying if you were hospitalized for COVID is much lower.
Okay, so that slide, Dr. Weiss, is to show that race and ethnicity are the risk markers for underlying conditions that affect health, including socioeconomic status, access to healthcare, and exposure to the virus related to occupation. I can see what you're talking about regarding the hospitalization, but again, the way it's presented, it's on CDC website actually. On a face value, you think that the hospitalization for the whites are higher, but when you look at the population of the number of when you look at the number of whites compared to blacks in a certain population, then you know that the percentage of blacks that are hospitalized compared to whites are higher.
Yes, that's clear. But why they should have better survival goes counter to what I'd expect based upon later time of presentation and higher levels of comorbidities.
Okay, yeah, I understand that, Dr. Weiss. If I had failed to explain it, but we know that minorities come with so many comorbidities that that it's higher propensity for them to get, even without coronavirus, for them to get hospitalized and die from illness compared to I get
Yeah, so it's the statistics go the opposite way.
Yeah, well, for the purpose of this presentation, that statistics showed, like I said, that statistics showed that the whites, the Hispanics, blacks, and American Indian, Alaskan Natives, that they die more from coronavirus compared to whites and other ethnic groups. So it all depends on if I'm looking at the exact slide, but we can take this and discuss this after the presentation. But based on the presentation and the way CDC all the data that and the slides that CDC presented regarding the difference in minorities, deaths, hospitalization compared to non-Hispanic whites, blacks, and American Indian and Alaskan natives, that the whites, those minorities die more, are mostly hospitalized based on percentage their population compared to the white population. Yeah, we'll discuss this more, Dr. Wise.
We can circle back on any one particular study or any one particular point in time. I know from doing some of this that sometimes there are things that are just because of us, it's a certain cut. So we have a question about whether New Jersey communities are taking enough advantage of some new grants from the CDC. There's, I guess, some grants called Strengthening Local Public Health Grants from NJDOH and the CDC, and allows for hiring new outreach coordinators. There's certainly, you know, new money that's come from every direction. You could talk about, you know, if you think that we haven't taken enough advantage, some of the structural challenges to actually taking advantage of some of those new funding opportunities.
All right, so I wish we had all this money coming in before the pandemic, because I keep saying this, we are not, public health is not well sustained. Public health departments around the country, they are not well sustained with the resources that they need. And yes, there are resources right now, and there are public health departments in New Jersey that are utilizing these resources, but we don't know if they will be sustained. What I say to people is that the police department, the fire department do not wait for burglaries to go from 0 to 100 and fires in the community for them to start hiring for police and for fire department staff. So public health needs to be sustained. We need to have staff on the ground, people that should be doing work before the next pandemic. And I appreciate the fact that CDC, NIH, New Jersey Department of Health, they are giving us a lot of money now, but where would this be in the next 5 years? Do we still have this sustained? We've been trying with the state government through all the commissioners that have served within the last 10 years to make sure that they bring back the public health priority funding for public health departments. Those fundings were taken away from us years ago, and we've been fighting to get these things down. And with this, we can hire more health educators that will be out of there in the community, trying to bridge the gap, the disparities in minority communities. But we do not have this as of now, but we have influx of funding that we don't know how long it's gonna last.
And it's always tricky to run an organization where you suddenly have money and then it goes away, and it's a big issue. I want to make sure we're actually at time. And so I want to make sure that people know when they can continue the conversation with this great community. We have the mayor of Paterson joining us for our next seminar in this series on December 2nd, same time, 11:30. I hope people will come back. As you see from this terrific conversation today with Dr. Nwako, leadership matters, and leadership in public health matters, and leadership in elected positions also is obviously has had a huge impact at every level of this pandemic. So please help me in thanking. You can use all of your reaction emojis. Please help me in thanking Dr. Nwako for today and for all of your work and leadership. We are so lucky to have you in New Jersey.
Thank you.
Tons of thanks in the chat.
Thank you. Thank you, everybody. And I appreciate you joining. This is Like I said, this is not a marathon. This is not a race. It is a marathon. So it is something that will continue chipping in, going from one to another. And we expect that in years to come, that disparity will continue reducing in our communities. It has started reducing. We want it to continue reducing and to stay that way. Just like we went from 55% of people that minorities in Camden City or the Camden City residents that were vaccinated in August. And now we are in November and we're over 70%. So we continue going little by little, thanks to Lou Bessage and the group here in Camden County that we've been working every week to make sure and that this happens. And to my team here at the health department, starting from Ann Walters to Karel Lasher, my assistant, who has been very good. And we've been working together to Rachel and to all the supervisors, Matthew and Corinne, Daniela, my able assistant, Donna. They've been all good. And please, we thank you all for all you do. Claudia, the whole group, thank you all, and God bless you all. You make my day so seamless.
Thank you again.